Okay, so welcome to the next module. This module is going to be mainly on medications that affect clotting. And we're going to talk about some clotting disorders so that the medications make more sense when we use them. And as well, we're going to talk about blood products that we can transfuse into patients and the complications when we transfuse those products. So when we think of clotting, we can think of it in a good way, meaning you're bleeding and your body is trying to stop the bleeding with two separate systems. The first system are your platelets, those little cells that float around in your blood, waiting to be activated and to form what's called a platelet plug in the leaking blood vessel. The other part of the system is the coagulation system that forms a very strong clot at the damaged vessel. So when we talk about coagulation, we're talking about platelets, and we're also talking about the coagulation system that we'll come to. Unfortunately, sometimes this system will lead to overclotting, where you will form clots when you don't need one, such as in a deep vein thrombosis in your leg. That can then break off, or part of it can break off, and travel to your lungs and form a pulmonary embolus. Now, the other side of the coin is when you have something wrong with your coagulation system. So, for example, you may be having a disorder where you're missing clotting factors that allow you to form a clot, such as in hemophilia. Or you're taking a medication that is inhibiting the coagulation system, that is stopping you from forming a clot. And there's also medications that inhibit the platelets, such as aspirin or non-steroidal anti-inflammatories, and they can stop the platelets from forming the initial platelet plug. Okay, and we'll go through all of these slowly, and then we'll follow that with some growth factors for the bone marrow, drugs that we can use that can stimulate the bone marrow, followed by blood products. So why do we use blood thinners that inhibit a very important system in our body, the ability to form a clot so that we can stop bleeding? Well, I would think of it as either an issue with a vein or an issue with an artery. If it's a blocked vein from a blood clot, such as a deep vein thrombosis in your leg, this will usually lead to symptoms in one leg only, since it would be unusual to have both legs having blood clots in them. So you will usually have a swollen, red, and tender leg, whether it's the left or right. And as that clot extends and gets bigger and bigger within the vein, parts of it can break off. And when a part of a DVT breaks off, it's able to travel now. It's able to embolize. And where does the clot embolize to? Well, it's going to go with the blood flow into the inferior vena cava, travel to the right side of the heart, and then the right side of the heart will then pump it to the lungs, and it will result in a pulmonary embolus. Okay, so pulmonary emboli typically come from deep vein thrombosis. Sometimes we'll use blood thinners to try and open up a blocked catheter that we're using, say for chemotherapy. The end that's within the patient gets clotted with blood, and we can no longer use the catheter, and sometimes we'll put a bit of a blood thinner into the catheter to try and break up the clot. But definitely the more common reason for using it is a blocked vein, such as a deep vein thrombosis or a pulmonary embolus. Okay, so when we're talking about arteries now, why would we use blood thinners? Well, if you have a blocked artery, whether it's to your heart or to your brain or to your leg, that's a problem. That's going to either lead to a heart attack or angina, if it's in your heart, a coronary artery. If it's in a cerebral artery going to your brain, it's going to lead to a potential stroke. And lastly, if it's in a peripheral artery, such as your femoral artery going to your leg, it's going to result in either a partial blockage of the leg, called intermittent claudication, and we'll talk about that, or a complete blockage of the leg, called an ischemic leg. There is no blood flow going to the leg. And that is an emergency. That leg needs blood flow to provide oxygen to the cells of the leg, and it will die over the span of hours if the blood vessel isn't opened. And lastly, we can use blood thinners to prevent blood clots, whether they're in the veins or the arteries. So for example, if someone has a history of strokes or has a history of heart attacks, we can use aspirin on a daily basis to thin their blood, to make the platelets less sticky so they don't form the initial clot. Okay? If somebody's lying in a hospital bed after surgery, or they're very sick with another condition such as pneumonia, we can use blood thinners as a prevention of deep vein thrombosis, to avoid them developing a deep vein thrombosis. And lastly, there's a condition called atrial fibrillation, where your heart doesn't beat regularly. It beats very, very irregularly. And when that happens, the chamber in the heart, in particular the left atrium, because it's not contracting regularly, it can form clots because of the very abnormal and unpredictable contractions. The blood doesn't flow well, and you form a clot, and that clot in the left atrium can then travel to the left ventricle and then embolize out into the system and lead to a stroke if it goes to the cerebral artery, or it can cause an ischemic leg if it travels down the aorta and gets plugged in one of the femoral arteries of the leg. So we use blood thinners to keep the blood from clotting in atrial fibrillation as well. Okay, so let's talk about a DVT, a deep vein thrombosis, or the other term, venous thromboembolism. Thrombo meaning a clot is there, embolism meaning part of it potentially can break off and travel to the heart and lungs. And you can see in the image that normally the blood is flowing through the veins, and there's valves and veins, by the way, you can see them there. In the middle image, you can see that there's a clot forming. And that clot hasn't broken off yet, but it's going to cause local symptoms of the leg, the swelling, the redness, the tenderness, because the blood can't get out of the leg. And lastly, bits of it can break off and embolize to the lung. So what are risk factors for a DVT? Well, anything that causes prolonged immobility. So lying in a hospital bed, distant travel on a plane where you're sitting in a plane for many, many hours, the blood flow is reduced out of the leg, so the blood has the potential to clot. What about surgery or trauma? Well, that can lead to a blood clot because you're immobilized, right? You're typically not moving. If, for example, you have a fractured leg and you're lying in a hospital bed, so that puts you at risk. Hypercoagulable states typically refers to certain conditions that patients have that lead them to have blood that clots easily. And there are diseases where people have blood that clots easily. And an example of that is a heavy smoker. Smoking makes your blood clot more easily. It makes your blood thicker. Cancers makes your blood thicker. So someone with an active cancer is at risk for a DVT and a PE. Pregnancy increases estrogens and progesterones in your blood, and estrogen thickens the blood. They are at higher risk for a DVT or a PE. And lastly, estrogen use, such as in a birth control pill, can also lead to a DVT. And that is the reason why we don't prescribe birth control pills to smokers very often, because smoking increases the risk, and then the birth control pill also increases the risk since it has estrogen within it. So think of a deep vein thrombosis as symptoms in the leg. So the swelling, the warmth, the pain, the redness from having a blocked vein, and the blood just can't flow out of the leg normally. So it makes sense that if you have a blocked, large, deep vein, the blood just can't get out. The leg's going to swell up. It's going to be painful, and it's going to be red. Okay? And if the thrombus breaks off a bit, a little piece of it breaks off and embolizes, that's how you get a pulmonary embolus. So basically the risk factors for a DVT are the same risk factors for a PE. Because where do PEs come from? A DVT. Okay, so let's look at a pulmonary embolus. You can see the clot that is traveling up the inferior vena cava. Where has it most likely originated from? From a deep vein thrombosis. And as the deep vein thrombosis gets larger and larger, it doesn't stay together, and pieces of it break off and travel to the lung and give a patient respiratory symptoms such as chest pain, shortness of breath, coughing up blood. Those are symptoms of a pulmonary embolus. And if you look at the risk factors for a pulmonary embolus, they're very, very similar to a deep vein thrombosis, since that is the risk factor for getting a PE, is having a DVT. All right, so when we're now thinking on the arterial side, we're thinking of arteries that are feeding different organs. So arteries feed all the tissue in your system. So a blocked artery to the heart can result in a heart attack. A blocked artery to the brain can result in a stroke. And a blocked artery to a limb will result in an ischemic limb. Okay? It's depriving one of those areas of oxygen. And when you deprive an organ of oxygen, it will result in hypoxia of the cells. And if it's long enough, which is typically hours, if it's blocked beyond that, the cells will start to die and you will get necrosis. Okay? So it's very important that in arterial thrombosis that we do something emergently, right? So if someone has a heart attack, we want to open up that coronary artery as fast as possible to start the blood flow back down the artery to feed the heart. And the same thing would go with a stroke, to open up the blood vessel, to provide return of circulation to the brain. And the same would be for a blocked artery in the leg. Okay, so if you have a blocked coronary artery that's completely occluded, completely blocked, that will result in a heart attack, a myocardial infarction. If you have a cerebral artery that's completely blocked, that will result in an ischemic stroke. That part of the blood, or that part of the brain that was receiving blood flow that is now blocked, is going to die if the artery isn't opened within hours. Okay, and here we are talking about peripheral artery disease. So a partial blockage or a full blockage of an artery that goes to a limb. And when we're talking about peripheral artery disease, we're usually referring to the legs. It's not as common to get a blocked artery in an arm. It's more often the legs. And if it's a partial blockage, where a bit of blood flow can still get through, then the patient typically has really no symptoms at rest because they're not using enough blood or oxygen to the leg to cause symptoms. But then when they go to walk and the muscles need more oxygen to provide movement, they then get what's called intermittent claudication. And that is the condition where you get pain and cramping in your lower legs when you start to walk or exercise, because now the leg is not getting enough oxygen due to the diminished blood flow to that leg. When the patient sits down and waits a few minutes, the pain will go away because now they don't need as much blood flow or oxygen to the leg, and the symptoms resolve, only to start again if they start to exert themselves. Okay, so we can use blood thinners in this setting to try and make the blood a bit thinner to allow it to flow by the narrowed artery. And what's caused the narrowed artery? It's typically atherosclerosis, and that is the plaques that form in our arteries that gradually block the arteries, whether it's in your leg, in your heart, or in your brain. What about an ischemic leg? Well, that's a complete blockage now. So that narrowed blockage, that partial blockage, has now completely blocked suddenly. Well, now there's no blood flow going down the leg, and this will give constant pain. This will give them completely no blood flow, so now they are in severe pain even while they're at rest. The leg will look pale because there's no blood going to it. It will start to go numb, called paresthesia. It will have absent pulses, so pulselessness is a symptom of a blocked artery to a leg, and pain. So think of the symptoms of a completely blocked artery to a patient's leg as pain, paresthesia, pulselessness, and pallor. And these patients need their artery opened urgently. Well, no, emergently. And that usually is a combination of surgery to get into the artery and blood thinners to keep the artery open. So this slide is showing a combination of symptoms more related to a partial blockage, and then also some symptoms more related to a full blockage of an artery to your leg. So the first one, intermittent claudication, we spoke about. That is, by definition, a partial blockage. When you get up and walk or go up a hill, you get leg pain, and it stops when you stop walking and sit down. So it's really like angina of the leg. We use the word angina for the heart, and what does it mean there? Well, when you go for a walk, you start to get chest pain. Why? Because you have a partial blockage in the coronary artery of your heart, and it can't provide enough blood flow and oxygen to the heart. Same idea, right? So we call it angina. In the leg, we call it intermittent claudication. Rest pain, well, that's a symptom of a completely blocked artery. Non-healing skin lesions, well, that's because there's not enough blood flow going to the leg. Whether it's a partial blockage or a full blockage, you don't heal well if you don't have the proper blood supply to the area. So they get ulcers and skin breakdown. Decreased or absent pulses. Well, decreased pulses in intermittent claudication, absent pulses if the leg is completely blocked, if the artery to the leg is completely blocked. Bruits just mean sometimes we can hear a murmur over where it's partially blocked because the blood flow is very turbulent there. It's not a nice smooth blood flow. So as the blood is trying to get around this partial blockage, it's turbulent, and we can hear it as a bruit. Subcutaneous atrophy just means that the tissue is starting to shrink away because it just doesn't have enough blood supply, and that's with a partial blockage. Alopecia, loss of hair to the leg, sure, a partial blockage. It's just gradually not able to feed the hair follicles. Coolness to the leg or pallor to the leg can be an indication of a partial blockage or a full blockage, right? The leg doesn't have enough warm blood going to it, so it's cool and it looks pale. Cyanotic blood, so blue toes, a blue foot, meaning the blood is flowing so slowly that it's deoxygenating. It has a bluish tinge to it. Okay? Dependent redness means that when someone's lying on a stretcher and they put the leg over the stretcher and hang it over the end, the leg suddenly turns much more red. And that's an indication that gravity is now helping blood flow down the leg. So it's now red again. And then if we were to lift the leg in the air, it would be pale because there's just not enough blood flowing by that blockage. Okay, so dependent redness. And you'll get relief when you hang your leg over the side of the bed. Why? Because gravity is now helping the blood flow a bit better across the blockage. Okay, so this slide is showing you images of patients' feet. On the left side, you'll see that the right foot has an arterial blockage of the right foot. How do we know that? Look at the paleness of that area. There's no blood going there. Look at the blue third toe. The blood is circulating so slowly that it's now deoxygenated and it's turning blue. On the other pair of legs, which one is affected? It's going to be the right leg again. And why is that? Well, the patient's hanging their leg over the side of the bed, and gravity is now helping it go from a pale appearance to a red appearance because the effects of gravity are helping a bit more flow down the leg. You can see that there is still a blue third toe? Now, if we were to lift that right leg up high into the air, it would turn pale again. And that tells us that there is very poor blood flow to the right leg. Okay, so let's move on to some medications that affect the coagulation system. And when we talk about medications affecting the coagulation system, there's two parts that we can affect. We can affect the platelets, those little cells circulating in your bloodstream that typically have a platelet count of 150,000 to 400,000, or we can directly affect the coagulation system that results in a fibrin clot, and we'll talk about that. And we can have anticoagulant effects by blocking that system. So think of it as platelets and this very strong coagulation system that is going to form a very strong fibrin clot to stop any further bleeding. Okay? Okay, so when we're talking about any particular drug, it has to be either an antiplatelet drug or an anticoagulant drug, because those are the two arms of the clotting system, right? So you'll see in this slide that the first four drugs, the first two being by far the most important, aspirin and clopidogrel, what do? They inhibit the platelets from working. They block a certain part of the platelet and they make them much less sticky. They don't aggregate together to form a platelet plug. Okay? These drugs don't reduce the level of the platelets. You'll still have a normal platelet count. They just won't be effective platelets anymore when these drugs are used. There's a couple of other antiplatelet medications that we'll talk about, but definitely aspirin and clopidogrel would be the most important. Okay. The rest of the slide, except for the last one, they're anticoagulants. They're going to impact the coagulation system, which is a series of clotting factors, which finally results in a very strong fibrin clot at the site of the bleeding. If we're talking about abnormal clotting, such as a deep vein thrombosis, it's still a fibrin clot, and we would want to use anticoagulants to treat a deep vein thrombosis or a pulmonary embolus. Okay, so until we get to those slides, just think of these, whether it's heparin or warfarin or enoxaparin. Any of these are just different drugs to inhibit the coagulation system. Okay, and lastly, we have a drug called alteplase, and we'll talk about it in a slide. And alteplase is in a group of medications called thrombolytics, or another term for them is fibrinolytic. So what's a fibrinolytic? Well, it's a drug that we use to break down a fibrin clot. So if someone has a heart attack, they have a fibrin clot in their coronary artery. If someone has a stroke, an ischemic stroke, they have a fibrin clot in their cerebral artery. And we can use one of these drugs in this group, alteplase, on an emergency basis to try and break up the fibrin clot that's causing all the problems. Okay, so we'll talk about these drugs. So this slide is not for you to spend hours going through every drug. Okay, this slide is just to categorize what we've been talking about. So how can we impact someone's clotting ability? Well, we have antiplatelet drugs. They don't work on the coagulation system. They work on the platelets, and they inhibit the platelets. They don't reduce the platelet count. So those are drugs like aspirin, non-steroidal anti-inflammatories. Clopidogrel is a common one that we use. So I would stick to the common ones that we're going to discuss. There's many there, but it's not necessary to know all of these. Just notice, by the way, that there's different groupings even within the antiplatelet category. So each one of those groups inhibit a different part of the platelet. So you can imagine if we gave someone a drug from every one of those groups in the antiplatelet category, they would have completely normal platelet count with absolutely no platelet function. We don't do that because it would cause a lot of bleeding, but just giving you an example. Anticoagulants, they are drugs that purely affect the formation of a fibrin clot. And we will go and we will have images of the clotting system and where these drugs can have an effect. And the final effect is the body cannot make a fibrin clot. The important ones in these groups that we'll talk about a bit, dabigatran, enoxaparin, heparin, and of course we're going to talk about warfarin. So again, they're categorized in different groupings even in this group of anticoagulants just because they have an effect at different areas of the clotting cascade. Okay? Thrombolytics, they're used in an emergency. So TPA is the most common one. And what do? We'll see on another slide that they directly will try and break down the fibrin clot to try and open up the artery in, for example, a heart attack or in a stroke. Okay? We call them plasminogen activators. Why do we call them that? Well, there's a protein floating in your bloodstream doing absolutely nothing called plasminogen. And when it's activated by one of these drugs, it turns into an active protein called plasmin. And plasmin will go right to the fibrin clot and try to break it down. Okay? Remember that the clotting system in your body is trying to stop bleeding. So it's forming clots to try and stop bleeding at areas of injury. But it also wants to break down the clot when it's time to get rid of it and the vessel is healed. So that's why we have plasminogen naturally in our blood that can be converted to plasmin so that it can break down the clot naturally. These drugs actively stimulate plasminogen to plasmin and force plasmin to break down any fibrin clots in the body. And lastly, herbal supplements. These are good to remember, just more importantly that you do get asked these on ATI and NCLEX. What herbal supplements can also thin the blood? And what should you avoid with other drugs that can also thin the blood? So for example, if someone was taking garlic, we would tell them to stop it if we were starting them on an anticoagulant or any blood thinner. So it's good to have an idea that certain herbal remedies can thin the blood. Actually, many of them do. So feverfew, garlic, ginger, these are relatively common herbal supplements, and they all thin the blood a bit. We would avoid them with prescription antiplatelets or anticoagulants. Okay, this slide, again, a bit of repetition never hurts. We have antiplatelet medications. What do? They reduce platelet adhesiveness. They reduce the ability of platelets to stick together and form a platelet plug. And we want that in certain conditions where we just don't want platelets to stick together and lead to, for example, a stroke or a heart attack. And that's why we give those patients aspirin every day to prevent that. Anticoagulants, they stop the formation of a fibrin clot, that very, very strong clot that heals a blood vessel. Why do we use them? Because sometimes we don't want someone to form a fibrin clot, such as in someone who's developed a DVT. We want to help break it down with an anticoagulant. Or sometimes we'll try and prevent a DVT and give someone an anticoagulant while they're lying in a hospital bed healing from a leg fracture. And they are at much higher risk of developing a DVT. Okay? And lastly, thrombolytics, we'll talk about those. We've already mentioned them, that they are used in emergencies to break down a clot in a heart attack or a stroke. Okay, so when we talk about antiplatelet drugs, the idea is not to look at this slide and try and memorize it. It's just showing you that different drugs work on a different part of the platelet. So they don't work at the same site. So we can actually use one, maybe two antiplatelet drugs, which would have even more of an effect on the platelets if we wanted to. In general, that starts to get dangerous because we're going to cause bleeding, right? The more you inhibit the coagulation system or the platelets, what's the biggest risk? Bleeding. Whether it's bleeding in the gastrointestinal tract, bruising in the skin, or bleeding in the brain, a hemorrhagic event in the brain, that can happen from being on anticoagulants. What are the common ones here? Clopidogrel and aspirin are by far the most common ones. We'll talk a bit about a few others, but this is just to show you that they're broken up into groups that have different actions on the platelet. Okay, so onward we go. This is just again reminding you that the platelet, that circle in the middle, is specifically affected by different drugs in different areas. So what are the important ones? Aspirin is a platelet inhibitor. Clopidogrel is a platelet inhibitor at a different site. And that was done on purpose so that if we combine these antiplatelets, they have additive effects. Okay? There's no need to memorize all the different information in this slide about collagen and thrombin and no, just understand that different antiplatelets work at different sites. So what are the main characteristics of antiplatelet drugs such as aspirin and clopidogrel or non-steroidal anti-inflammatories? Well, they interfere with platelet aggregation and stickiness. They try to prevent that platelet plug from forming, which is good if you're bleeding from a site, not so good if the platelet plug is forming abnormally, leading to a blood clot, for example, in your leg. Okay, but in general, the platelet plug is the first part that forms at a bleeding site. And you'll see the different drugs here that all are platelet inhibitors. Okay, that's all they are. They're different drugs that can be used to block the action of platelets. Okay, so let's start with the most common one, aspirin. It's been around easily for over 100 years. And what do we use it for? Well, years ago it was actually used as a painkiller. But now typically we use non-steroidal anti-inflammatories such as ibuprofen if we wanted to use an anti-inflammatory as a painkiller or for fevers. Aspirin is mainly used for its antiplatelet effects. So we can give it to someone with coronary artery disease, CAD, or with a history of cerebral vascular disease, previous strokes. And by giving aspirin, it prevents platelet aggregation, reducing the chance of a clotted vessel, a clotted artery when we're talking about heart or a stroke. Okay? So how does aspirin work? Well, it works by reducing prostaglandins. That's not very important at this stage. The most important is that it's an antiplatelet. What are the adverse effects of this group? Aspirin, or for that matter, any non-steroidal anti-inflammatory? Well, when taken regularly, they all lead to hypertension. Okay, they all raise the blood pressure a bit. They all irritate the stomach and can lead to either gastritis, which is inflammation of the stomach, or a peptic ulcer and bleeding. So need to be aware that any non-steroidal anti-inflammatory aspirin can lead to peptic ulcer formation and bleeding. They're tough on the kidney function. The kidneys rely on prostaglandins to function properly, and aspirin inhibits prostaglandins. So it's going to reduce kidney function. Salicylism is really a condition of aspirin toxicity. Too much aspirin in the system. Not very common anymore. It was more common when people were taking high doses of aspirin for their pain. We don't typically do that anymore. We usually take too much ibuprofen instead. But salicylism is the syndrome of aspirin toxicity. Lastly, Ray's syndrome, or Rye's syndrome, was a condition that was noticed decades ago where young children with viral infections, when given aspirin, the combination would lead to liver failure. They would have severe hepatitis, and some died from liver failure, and we called it Rye's syndrome. So aspirin is not indicated in children. In fact, I think in your ATI book, it's under the age of 19 who have a viral illness. Rye's syndrome was most commonly seen in young children that were given aspirin. Okay, so who do we avoid aspirin in? Well, if you have a history of hypertension, we should probably avoid it. If you have severe renal disease, it's going to make it worse, so we should avoid aspirin products. If you have bleeding disorders, or if you have a history of peptic ulcer disease, we should avoid aspirin products and NSAIDs because we might reactivate the bleeding in your stomach. And of course, if you're on other anticoagulants, we'd be careful to give you aspirin because now you're on 2 blood thinners, right? And lastly, the Rye syndrome that we just spoke about. So really, it's important to remind people of the risk factor of any anticoagulant they're on, or antiplatelet, right? So that is the biggest and most concerning side effect when we're talking about anticoagulants and antiplatelets. We also recommend patients that are having elective surgery, so they're going in, say, to have their gallbladder removed, to stop aspirin at least a week before the surgery to allow the platelets to return to normal function. Okay? When you're taking aspirin or non-steroidal anti-inflammatories such as ibuprofen, taking them with milk or food is a good idea to buffer the stomach a bit to avoid that irritation. We often advise patients not to chew or crush aspirin when they're taking it daily, since many of them are coated. They're enteric coated, that allows the aspirin to get through the stomach and not have its effect on the stomach. So if you crush them or chew them, you've broken that coating and they're not effective. It's not protective anymore to get through the stomach. Avoiding other irritants such as alcohol or lots of caffeine in coffee, because that's a gastric irritant, would be a good idea. Okay. Smoking is hard on the stomach. You're swallowing all those carcinogens and toxins, and it irritates the stomach. And smoking is actually a risk factor for stomach cancer. So smokers that are taking aspirin, sure, there's many patients that are, but they're more at risk for bleeding from the stomach. And lastly, asthma. So asthma and aspirin, they don't really get along. Patients that have significant asthma, when they take aspirin or some non-steroidal anti-inflammatories, they wheeze more. It irritates their asthmatic condition. So we often advise asthmatics to avoid aspirin products. Okay, so the discussion on aspirin is going to make clopidogrel relatively straightforward. Just another antiplatelet medication. So we can use it just like aspirin to prevent a heart attack in someone with coronary artery disease, meaning a blocked coronary artery or a partially blocked coronary artery, and we want to stop the platelets from aggravating the blockage. Or a patient who's had a previous stroke, we can use clopidogrel instead of aspirin. Or patients that have just had a stent put in due to a blocked coronary artery in their heart. So we've put the cardiologist has put a stent through the blockage, and often patients end up on clopidogrel to stop any platelets from sticking to the new stent. Okay, and they often will stay on it for a year to prevent any aggregation of platelets on the stent. Okay, so it's a platelet inhibitor. What are the adverse effects? They're all going to be bleeding, right? Gastric bleeding, gastric irritation. So that is what we're going to warn patients about, the risk of bleeding. When wouldn't we use clopidogrel? Well, if you already have low platelets, so under 150,000, you're definitely going to inhibit the remaining platelets that are still functioning. So that would be a higher risk for bleeding because they already have low platelets, thrombocytopenia. If somebody has a significant history of bleeding ulcers or a history of a hemorrhagic stroke, well, you could aggravate those conditions by stopping their platelets from functioning, leading to a bleeding ulcer that's been reactivated. Okay, so really the big thing about clopidogrel and aspirin for that matter is the bleeding risk, and also monitoring and telling patients that if you have black stools, which is melena, which is blood coming from your stomach, or hematemesis, which is vomiting of blood, then you need to let us know, because that may not stop bleeding because of the clopidogrel. And a dose of clopidogrel or a dose of aspirin inhibits the lifespan of a platelet, which is typically about 7 to 10 days. So once it takes about 7 to 10 days once you've stopped these drugs for them to completely clear out of your bloodstream and have no platelet effect. Okay, I'm going to spend less time on the next two. Dipyridamole is basically an older antiplatelet. We don't use it as much anymore. So I would say it's used really for the same conditions as aspirin or clopidogrel. It's a platelet inhibitor. It will cause the same side effects of bleeding and upset stomach. So we advise patients to take it with food. And if their platelet count is low, we definitely don't want to use any antiplatelet drug, such as this one, or aspirin, or clopidogrel in patients with low platelet counts. Okay, because we just put them at risk for bleeding. Okay, so the next prototype, abciximab. This is just another antiplatelet medication. This happens to be an intravenous antiplatelet medication that's really used during a procedure such as stent insertion for a blocked coronary artery, or for someone who's in hospital with severe angina awaiting surgery. And this drug is doing everything it can to stop the platelets from completely blocking the coronary artery. Okay? So we're not going to spend a lot of time on this. This is not as important as aspirin or clopidogrel. And of course, it's going to have the same adverse effects because of its inhibition of platelets. The gastric bleeding, the potential for hypotension if you bleed enough, right? So whenever you have hemorrhagic bleeding, you're always potentially at risk for hypotension if you bleed enough. Okay? This wouldn't be used for very long. It would be used for a day or two, just until surgery can be done. And of course, what's the biggest risk of an intravenous antiplatelet drug? Bleeding. Okay, I think that's all we need to go over for this drug, just to be aware that we do have intravenous antiplatelet drugs. Okay, so when we're using anticoagulants that block the coagulation system, we often need to monitor how much are we blocking the system. How much are we inhibiting the system from forming a fibrin clot? And that's important because if we give too much of the drug that's inhibiting the coagulation system, they're at higher and higher risk of having a very severe bleeding event. So for some drugs, we have blood tests that we can check the degree of inhibition of the coagulation system. And we'll talk about some of those. Okay, so some of these won't be very clear until we actually talk about the coagulation cascade, which is basically a map of different clotting factors in the blood that stimulate each other and then form the final fibrin clot, which stops the bleeding. Okay, so it'll make a bit more sense as we talk about the coagulation cascade. But these are some of the tests we can do to monitor certain drugs. So for example, the first two, in particular, the INR, International Normalized Ratio, that's kind of replaced the prothrombin time, the PT, to monitor warfarin, or the other term for it is Coumadin. So the only drug in that group that we're talking about is warfarin, that we can use INR to monitor how much are we inhibiting the system. Are we making the blood too thin in terms of its ability to clot. Okay, and we'll come back to that. So just to mention, PT is not used as much anymore because we have a more effective test called the INR for monitoring warfarin. Okay? PTT, partial thromboplastin time, is used to measure another part of the clotting cascade when we use drugs that are called heparins. And we'll come to those as well. Okay, so INR, warfarin. PTT for heparins. What are those drugs? They're anticoagulants. They're blocking certain aspects of the coagulation cascade. What else can we check in the blood for someone who we think is having a clotting issue, or we want to monitor a drug that they're on? Well, we can check a platelet count to make sure that their platelets are at an appropriate level of 150 to 400,000. We can check a bleeding time. Well, what's a bleeding time? It's where we nick someone's arm with a sharp knife, just a little nick, and we count how long is it going to take for the bleeding to stop. And that really measures the platelet activity. Okay? Because what are the first cells that come to form a little plug are the platelets. So when we nick someone's arm, we're actually measuring a bleeding time to see that the platelets are effective to stop the bleeding. And typically that's about 3 to 9 minutes, a normal bleeding time. And lastly, we can measure liver function tests, because the liver is where all the clotting factors are made. So if you have a very diseased liver, you're not making clotting factors. And that's why patients that have severe liver disease or cirrhosis, they have all kinds of bleeding problems because they have very low levels of clotting factors that are circulating in their bloodstream. Okay, so let's just talk about this test that we use to try and detect clotting going on in the body. It's called a D-dimer test. Okay, the tests that we just spoke about are more for monitoring of drugs that were given, such as INR, PTT, platelet count, to see what are we doing with the coagulation system when we're giving drugs. This test is used to see if there's any clotting occurring in the body when we suspect a DVT or a PE. So for example, somebody comes in with a swollen leg and a tender leg, and we're suspecting it might be a deep vein thrombosis. We can order this test called a D-dimer, and if it's negative, it essentially rules out a blood clot in the lung, a PE, or a blood clot in the leg, a DVT. So what is this test? Well, I mentioned before that a clot is constantly being formed and the body is constantly trying to break it down. And that's just the active process of what's going on in many systems of your body, building up and breaking down, right? That happens in your bones with osteoblasts and osteoclasts. Well, this blood clot is being built up, say it's abnormal, like a DVT. Well, the body's trying to break it down. And when it's breaking it down, it's actually releasing what are called D-dimers into the bloodstream from the breaking up of the clot. So elevation of D-dimer can be an indication of a DVT or a PE, because there's active clotting and breaking down of clotting in the bloodstream. And that's why we do this test. And that's when you're going to see it ordered in a hospital, when there's a suspicion of a DVT or a PE. Okay, and if the test comes back elevated, then we need to go on to a more specific test to look for the blood clot, such as an ultrasound of the leg or a CAT scan of the lung in the case of a pulmonary embolus. If the test comes back completely normal, then our suspicion is much reduced and we don't tend to order those tests. So it depends on whether it's elevated or if it's normal. So just know the concept that a D-dimer test is used to look for DVTs or PEs. Okay, so we spent some time talking about antiplatelets. We're going to go in more depth for anticoagulants, drugs that inhibit the coagulation cascade. Okay? And when you block a clotting factor in the coagulation cascade, you reduce the strength and also the formation of the final product called a fibrin clot. Okay? So as a general term, are antiplatelets or anticoagulants called blood thinners? Sure. But if you're being more specific, then we're talking about antiplatelets and anticoagulants as slightly separate. Okay? They don't change the thickness of the blood or the thinness. Sometimes we say that they're thinning the blood. What they're actually doing is they're stopping coagulation from forming. Okay? They inhibit all those clotting factors to cooperate together to form the fibrin clot. That's what these drugs are doing. Okay? And they do them at different sites in the clotting cascade. And when I say clotting cascade, I will show you on one of the slides what a clotting cascade is that's occurring in the bloodstream when it's activated. So what's the biggest risk factor for using any anticoagulant? Well, bleeding, right? You are stopping the formation of a fibrin clot. You are putting the patient at risk for bleeding because we want to treat a certain condition such as a DVT or a PE. Okay? So that is the biggest risk factor for anticoagulants. And the result of using anticoagulants is stopping formation of the fibrin clot. And that's why they can bleed more, right? So if they had a peptic ulcer that wasn't bleeding and they're on anticoagulants and that ulcer starts to bleed a bit, it tends not to stop bleeding when you're on an anticoagulant because the blood just can't form a fibrin clot. Okay, so don't let this slide stress you. We're looking at it from a big view. Okay, so it really is the amazing clotting cascade. All these numbers that you see, 12, 11, 9, all those are just different clotting factors in your bloodstream that are floating around naturally. They're all proteins. Where have they been produced? In the liver, right? Just like most proteins in the body, they've been produced in the liver. And when this system is activated, it goes down this cascade to the final product being a stable fibrin clot, which has stopped the bleeding, which was the intention in the first place, because this system is to protect you from bleeding to death. Okay? So that's why this is an amazing system, because it's there to protect you from bleeding to death. So what's the first system that comes in to plug the bleeding hole? The platelets, forming the platelet plug. What's the next system that comes in? The clotting cascade, forming a very strong fibrin mesh. What's the problem with this clotting system that we have? Well, it can sometimes cause unwanted clots in the veins, as we mentioned earlier in this module, or in the arteries. And that's when we use anticoagulants to inhibit a part of this cascade. Okay? And when we inhibit a part of the cascade, yes, we treat the underlying disease that they have, whether it's a DVT or a PE, and we accept the risk that patients can potentially bleed much more. So let's just look at the two arms of this clotting mechanism, this clotting cascade, the intrinsic system and the extrinsic system. Well, the intrinsic system just means that the inside of the blood vessel has somehow been injured. And that arm, the intrinsic system arm, has been activated. The extrinsic system just means that the blood vessel has been extrinsically injured, meaning there's been an injury to the entire blood vessel and blood is now leaking out of that system, of that injury, and you've activated the extrinsic system by having cut open the blood vessel. The extrinsic system, if you look at it, it's much faster. It goes from almost directly down with a straight arrow to close to the bottom of the coagulation cascade and leading very quickly to a fibrin clot, which makes sense. If you've cut open a blood vessel, you want to clot up fast. The intrinsic system is a bit slower. It has more proteins, more clotting factors to go through. Okay? What inhibits the intrinsic system? Typically the heparin type drugs that we'll talk about. What inhibits the extrinsic system? Typically warfarin. So what do we check to make sure that warfarin isn't inhibiting it too much? INR. What do we check to make sure that the heparin isn't inhibiting the system too much? PTT. Okay, so we'll keep on going here. Okay, so just ignore all these colored drug names. Just another way to look at the system, right? The coagulation cascade, which is really quite amazing. All these floating proteins that we've numbered, starting with number 12 on one side and number 7 on the other side, they're all inactive in the bloodstream. And then when they become activated, they cascade down and form the fibrin clot, or a thrombus. A thrombus and a fibrin is the same term, right? And we can look to see where do certain drugs act on this system. So if we're talking about heparin, well, it'll show you where heparin is working. Would I spend time memorizing where all these drugs are working on this slide? No, I don't think that's realistic or necessarily a good way to spend your precious time. Okay, so it's just to know that different drugs affect different sites of the coagulation system. That's the most important concept. Okay, so let's talk about a prototype medication that's an anticoagulant called heparin. And heparin inhibits the intrinsic arm of the coagulation cascade. It still leads to the same effect of stopping fibrin clot formation. Okay, what do we use as a blood test to make sure heparin isn't having too much of a anticoagulant effect? PTT, right? The partial thromboplastin time. Okay, so what do we use heparin for? Well, we can use it for a DVT, to stop the coagulation system. We can use it for a PE. We can use it for blocked arteries in the heart, such as in a heart attack or in severe angina. Or we could just use it for someone who's lying in a bed and we don't want them to develop a DVT. So we'll put them on heparin to prevent the formation of clotting in the veins. Okay? So the action is really inhibiting the fibrin clot formation. And you're going to hear that a lot, because really that's the most important part of what you should know about anticoagulants. It's not all those different numbers in the coagulation cascade. What are the adverse effects of giving heparin? Well, definitely you can imagine bleeding from anywhere is an adverse effect when you block the coagulation cascade. But heparin also has this really strange side effect on the platelets. So its main effect is to block the coagulation cascade, but it also can significantly reduce platelets in the bloodstream. So heparin can cause platelets to drop significantly below 150,000. Well, you can imagine if heparin's blocking the coagulation cascade and also reducing platelets, that could potentially lead to a very bad combination that can result in bleeding. Okay, so low platelets and blocking the coagulation cascade due to an adverse effect of heparin, the heparin-induced thrombocytopenia, and we call that HIT, H-I-T. Okay, so bleeding and HIT, heparin-induced thrombocytopenia, by far the most important adverse effects of heparin. Why can it cause hyperkalemia? Well, it's only because of the packaging it comes with, that there's some potassium in it. So that's not a big effect. Okay, remember the first two. Those are the big adverse effects of heparin. Okay, so when would we not use heparin? Well, if you have active bleeding, we're definitely not giving you heparin. If you already have low platelet counts, well, because of that adverse effect of heparin causing a lowering of the platelets, we're not going to give you heparin. And if you've just come out of surgery, say you've had abdominal surgery, we're not going to put you on full dose heparin because you could easily bleed from the surgical site. Okay? And another one is severe hypertension. So if you have very, very high blood pressure in your arteries, putting you on heparin could lead to a hemorrhage. So we wouldn't give you heparin if you had out of control hypertension. Okay, so what about nursing considerations? Well, this is only an IV drug unless we're using it to prevent a DVT after surgery. We just give a small dose subcutaneously in the abdominal tissue. Okay, so we give an injection just subcutaneously in the abdomen as a prevention dose after a surgery while you lie in bed. For full dose, it's intravenous. And we can use heparin in pregnancy. It doesn't cross the placenta. Okay? What do we monitor? We monitor the PTT. Okay? And typically, we'd like to see the PTT in a certain range, and that tells us that the heparin is having its proper effect on the coagulation cascade. We also need to monitor platelet count in hemoglobin. Why? Because of that adverse effect of heparin-induced thrombocytopenia. We need to follow that platelet count when they're on heparin for days and days. And of course, when someone's on heparin, they always receive the advice in hospital, if you have any black stools or tarry stools, or if you vomit any blood, then please report it. When someone vomits blood that's been in the stomach, it usually comes up looking as coffee grounds, and that's why we call vomiting of blood coffee ground emesis, because it really looks like the acid has an effect on the blood that makes it look like coffee grounds. Okay. And lastly, we would avoid aspirin or non-steroidal anti-inflammatories when we're giving someone heparin, because those will inhibit the platelets. Okay. Okay, so let's just talk about a slightly different drug, but it's still called a heparin, a low molecular weight heparin. And why were these created? Well, you can see on the previous page that heparin intravenously requires a lot of work. You have to monitor the PTT frequently. You have to adjust the heparin intravenously based on the PTT. So if the blood is too thin, meaning it's not coagulating at all, and we have to reduce the heparin dose. And if it's too thick, meaning there's too much coagulation, then we have to increase the heparin dose. And this goes on and on throughout the day as we check the PTT. Well, these molecules, the low molecular weight heparins, don't require any monitoring. They're weight-based, and they've been shown to give predictable anticoagulation without any monitoring. That's fantastic. Okay, so we can use this as a heparin without any monitoring. They're given subcutaneously in the abdomen, the abdominal tissue, never around the umbilicus. Okay, we avoid injections around the umbilicus because that's basically scar tissue where you had your umbilical cord. So we don't inject there. As I said, there's no need for a PTT. It gives reliable anticoagulation. So we've transitioned a lot to these low molecular weight heparins because intravenous heparin is much more labor intensive. So let's look at a prototype low molecular weight heparin, which again behaves very similar to a heparin, but without all that testing that's required to follow intravenous heparin. So enoxaparin. So very similar ending, right? Because it has heparin effects still. So we can use it in the same conditions, right? Blood clots in the lungs, blood clots in the legs, a blockage of a coronary artery, unstable angina, or a heart attack, an NSTEMI or a STEMI. Those are just different types of heart attacks. Again, it does the same action. It prevents the final product of the coagulation cascade, that powerful fibrin clot. What are the adverse effects? Same as heparin, those two concerning ones. You can bleed or hemorrhage, and it can also cause heparin-induced thrombocytopenia. Okay, not to the same extent as heparin, but it can still cause it. So we avoid this drug, again, in similar situations as heparin. Active bleeding, low platelet counts, severe hypertension. Why is renal disease listed under heparin and this one, enoxaparin? Because both of the drugs are excreted in the kidneys, and if the kidney is very, very weak in chronic renal disease, these drugs aren't excreted very well, and they can build up to much higher levels. So we're much more careful using these in patients with chronic renal disease. As I mentioned, no lab monitoring necessary. We inject this subcutaneously in the abdomen. The sites are rotated. If you're giving this once or twice a day, you go to a different site, right? You don't inject into the same site over and over. And typically you can see where you've injected because there's a little bruise that's formed there. And you'll see this on patients' abdomens that are getting enoxaparin. They'll have a little bruise where they received the injection. When you inject it, don't aspirate, don't pull back on the syringe, and don't rub the site. Okay? It's just injected and that's it. Rubbing the site can increase absorption too quickly. Advising the patient for monitoring for bleeding would be the same as for heparin, and avoiding aspirin or non-steroidal anti-inflammatories would definitely apply to this drug as well. The very nice thing about this is the lack of need for testing. Okay, so we weigh the patient, we find out how many kilograms they are, and we calculate the enoxaparin dose based on their weight. Okay, so we spoke about a few heparins just now. Let's move on to another drug called warfarin. It is an anticoagulant as well. It works at a different site in the coagulation cascade. What's the end result? Reduced fibrin clot. Okay, this particular drug, warfarin, inhibits production of vitamin K dependent clotting factors. Okay, so there's certain clotting factors that are made in the liver that require vitamin K for their production. Warfarin inhibits those clotting factors. Okay, so it's a vitamin K antagonist. And by blocking vitamin K, those clotting factors aren't produced. And what does that result in? Well, missing clotting factors in the coagulation cascade results in a weak or reduced fibrin clot, which is exactly what you want to do when you're using warfarin. Stop the blood from clotting. Okay? And we'll move on to the prototype slide and we'll talk about it a bit more. Okay, so warfarin is taken by mouth. It's an oral anticoagulant, right? Heparin, remember, was typically given intravenously. So what can we use this for? Well, anywhere where we want to stop clotting. So a deep vein thrombosis, a pulmonary embolus, a patient with atrial fibrillation that could form a clot in their atrium, or a patient with a mechanical valve. So if a patient has a metal valve, the platelets and the clotting coagulation system would love to stick to it because it's foreign. And we use warfarin to stop the coagulation cascade from clotting off the mechanical heart valve. How does it work? We just mentioned that. It antagonizes vitamin K dependent clotting factors, meaning vitamin K clotting factors cannot be produced, and since they're missing, the coagulation cascade has been inhibited. What's the main adverse effect of warfarin? Bleeding, right? Increased risk of bleeding anywhere. Gastrointestinal tract being the most important. The other ones are much less important, okay? When you see warfarin skin necrosis, I'll just as an aside, I'll just mention it. Initially, when you take warfarin, you actually don't have blood thinning effect at the beginning. You can have the reverse effect. You can have too much clotting It's just how warfarin works. Right at the beginning, it can cause um, more clotting than usual. And when that happens, you can get all kinds of clotting in the skin. And that leads to warfarin skin necrosis. It's not a very common side effect, okay? The most important side effect for warfarin is bleeding. Okay, so when are we going to avoid it? If warfarin makes you bleed, we're not going to give it to someone with low platelets, or someone with uncontrolled bleeding already, or someone that's just come out of surgery, or someone who has a liver disease, because the clotting factors are made in the liver. So if someone already has a weak liver and is probably not making many of the other clotting factors, we're definitely not going to make it worse by giving warfarin. Okay? And lastly, alcohol. So alcohol is an irritant to the stomach. If you're on warfarin, you can definitely bleed from the stomach because the alcohol irritates the stomach so much and leads to bleeding. And then the warfarin inhibits the coagulation cascade. As well, alcohol injures the liver. And when alcohol injures the liver doesn't produce as many clotting factors, so it's best to avoid warfarin. So warfarin is usually administered at the same time daily. How do we monitor it? With an INR. What else do we check in the blood? We'd probably just check a CBC just to make sure that their hemoglobin isn't gradually dropping from a bleeding in the gastrointestinal tract that we just don't know about. So once in a while we'll do a CBC when someone's on warfarin. INRs are done very frequently at the beginning of starting warfarin. So when someone starts warfarin, it's not like it has a blood thinning effect immediately. It takes 4, 5, 6 days to get to a therapeutic level of an INR between 2 and 3. So a normal INR in someone not taking warfarin is 1. That's just the number that's been chosen. An INR of 2 to 3 is where we want to try and keep people that are on warfarin. And the higher the INR, the more anticoagulation effects will occur. So a patient with an INR of 6 has very inhibited coagulation, and we wouldn't want to leave someone at an INR of 6. We'd want to reduce it back into the range of 2 to 3 because they're at such a high risk of bleeding. And how can we reverse warfarin? By using vitamin K. So we can give a dose of vitamin K either orally or as an injection. That will help those clotting factors that warfarin's been inhibiting to start being produced, and that will help with coagulation and bring the INR back down to between 2 and 3. Now remember, I mentioned that warfarin takes 4, 5, 6 days to reach a therapeutic level. And how do we know the therapeutic level? The INR. So in those first 5 or 6 days, we need to use a blood thinner that works immediately. If we're treating, say, a blood clot, we can't wait 5 or 6 days for the Coumadin to start, or the warfarin to start having its effect. So often we have to give injections of low molecular weight heparin, or we could use intravenous heparin, which have an immediate effect of blood thinning, of anticoagulation, and we'll wait until the INR reaches 2 to 3, and then we can stop the heparin product and continue on just with the warfarin. And we frequently do INRs at the beginning of starting warfarin, usually every day or every second day. Once you're stable on warfarin and your INR is between 2 and 3, then we can go as far out as a month of blood testing. So we can just have an INR every month. Okay? We don't ever go out any further than a month. A month is the longest typically. Okay, so some advice to patients that are on warfarin: avoid alcohol, avoid aspirin, avoid non-steroidal anti-inflammatories. Consider wearing a medical alert bracelet to tell healthcare providers, nurses that you are on warfarin, especially if you're unconscious. Okay. The bleeding precautions are: don't put yourself in a position where you're going to injure yourself, such as being on a ladder and cleaning the eaves troughs, being on the roof of the house, because if you fall, you're going to bleed a lot. Okay? And lastly, the dietary teaching. What we tell people is eat your regular diet, and don't alter it. That doesn't matter how much vitamin K is in your diet. We'll give you enough warfarin to reach a level of the INR between 2 and 3. If you significantly change your diet, for example, you start to eat tremendous amounts of spinach, which happens to have a lot of vitamin K, then notify us, because we may need to increase your warfarin to keep your INR between 2 and 3. Okay? So that's the dietary advice. It's not to avoid vitamin K, it's just to have your typical diet, and if you plan on changing it significantly, to let someone know. Okay, so the next two drugs are relatively new in the past 7 to 10 years, and they're anticoagulants. And I gave you the analogy or the example of where we use low molecular weight heparins instead of heparin because there's no testing required. Well, this applies to the next two drugs. Instead of using warfarin that requires frequent INR testing, we can use dabigatran as an anticoagulant, and it needs no testing, no regular testing to see its anticoagulant effects, which makes taking the drug much more easy for the patient. They don't have to go to a lab or a clinic. They don't have to have it adjusted because it's a fixed dose. Okay? It's used for the same indications as warfarin, except mechanical valve. Only warfarin can be used to prevent clotting with a mechanical valve. All the other ones are the same. The DVT, the PE, atrial fibrillation, to stop the clotting. Okay? And again, what does it do? It stops the fibrin clot from forming. How does this one do it? It directly inhibits one of the clotting factors called thrombin. And if you go back to the clotting cascade, you will see thrombin, and you'll see that this drug inhibits it directly. So, and that's another advantage of these drugs. They work immediately. Warfarin takes 5 or 6 days to reduce the clotting, certain clotting factors. This one and the next drug work the same day. There's no need to give low molecular weight heparin or heparin until the drug becomes effective. Okay? So what are the adverse effects? Bleeding. It's always going to be bleeding with anticoagulants. So it can cause some gastrointestinal discomfort, but it's going to be the big concern: bleeding. So when do we avoid it? Anyone who has any kind of active bleeding. And again, because this one is excreted directly through the kidneys, we try to avoid it in people with severe renal disease. So under nursing considerations, we would be careful not to give these patients aspirin or non-steroidal anti-inflammatories because this is an anticoagulant, okay? And there is no requirement for testing, and there is no requirement to give heparin or low molecular weight heparin at the start of giving this drug to wait for it to be effective, because it's effective immediately. Okay, this next drug, most of the information that I gave you about dabigatran applies to this drug. It has the same indications. It inhibits a slightly different clotting factor called 10A. And if you go to the clotting cascade, you'll see where 10A is. It's very close to the bottom of the clotting cascade. So in the end, it again inhibits fibrin formation. And you'll notice that in the drug name, it has 10A, XA in the name. And that was done on purpose because that's what it inhibits, factor 10A. The most concerning adverse effect, there it is again, major bleeding. When would we avoid it? Someone who's actively bleeding or who has low platelets. So again, this requires no blood testing. It's a fixed dose for all patients. We advise them, just like if they're on warfarin, to avoid falls, to avoid risky activities where they could injure themselves. And it has the same risk of bleeding, just like warfarin or dabigatran. One last thing to mention about dabigatran or rivaroxaban is that they don't work through the same mechanism as warfarin. So giving patients vitamin K will not have any effect on these drugs. Vitamin K is only for warfarin to reverse some of its effects and to try and lower the INR back between 2 to 3. Okay, this is a relatively old anticoagulant, fondaparinux. So you can see the parin in there. So it'll have some similarities to a heparin product, but basically it can be used again for clotting disorders like DVT or PE. We don't use it as much anymore because of the newer ones we have. That it's just not as popular. It will still cause hemorrhaging. That's the main adverse effect. And we would definitely avoid this in someone who's having any active bleeding or low platelet count. And of course, severe hypertension. There's no monitoring that's required. Rotation of sites in the abdomen are used. So it really sounds like a heparin type product, right? It's a similar, it's very similar to a low molecular weight heparin. That's how it's given, right? Subcutaneous shots to the abdomen, no testing required. We would definitely avoid aspirin and non-steroidal anti-inflammatories. So it's just an older anticoagulant. Okay, so let's talk about thrombolytic drugs, or another term for them, fibrinolytic drugs. These are drugs that are used in emergencies, such as a blocked artery to the brain, called a stroke, a blocked artery to the heart, called a heart attack. So what do these drugs do? How do they act? They convert a protein in your blood called plasminogen to an active form called plasmin, and plasmin can directly break down the clot, the fibrin clot, and that's why they're called clot busters. Okay, so we can rely on these to hopefully open up a blocked artery. What's the risk factor of these drugs? Well, you can imagine that all over the body, when we inject these drugs, they will break down anywhere where there's been a fibrin clot. So if you had any other site of bleeding, whether it's in your stomach, your intestines, your colon, anywhere, it will break down that fibrin clot as well. And you can have massive amounts of bleeding. So that is a very big risk factor for using these drugs. And patients are definitely advised when they receive this drug during their heart attack or during their stroke that they have to accept the 1 to 2% risk factor of a massive hemorrhagic bleed. Okay, so here is a fibrinolytic or a thrombolytic, same term. So whether we're talking about tissue plasminogen activator, TPA, or alteplase, they work the same way. They activate plasmin to break down the clot. When do we use them? Acute heart attack or acute ischemic stroke. Sometimes, as a last-ditch effort, if someone has a massive blood clot in their lung and they're dying, sometimes we'll inject a thrombolytic to try and break up this massive pulmonary embolus. Okay, so those are the most common reasons for using it, to dissolve a clot that's already formed. The adverse effect, very serious internal or external bleeding. Okay, so if you've had any recent surgery, if you've had any kind of gastrointestinal bleeding, if you're taking warfarin and your INR is elevated, or even in the range of 2 to 3, that's a reason for not receiving alteplase. Okay? So very careful using this drug because of the significant risk of bleeding. And another one, severe hypertension. This drug causes such blood thinning effect, such an anticoagulant effect, that if you have severe hypertension, we just won't use it. The risk is too high. So in strokes, we need to get this drug in within 4.5 hours of the onset of the stroke. So this will likely change with time. So the number of hours may be different when you're listening to this tape. So currently it's up to 4.5 hours. Okay. What do we monitor? We monitor for any sites of bleeding after they've received this drug. We also monitor to see if it's opened up the blood vessel. During the stroke, we're hoping that we're going to get return of neurological function. If it's an artery in the heart, we're hoping that the chest pain resolves and their ECG changes improve. So it just depends on which one we're using it for. After we've given the drug, we limit the number of injections and venipunctures that they're getting because they're just going to ooze from those sites. Okay, so we try to limit the amount the amount of testing we do after they receive this blood or this product. Sorry, I won't get too much into any reversal agent. It's not highly effective for this. Just know that what this is used for, that it breaks down the fibrin clot, and that it can be used for acute strokes and acute heart attacks. That's the most important. Okay, let's move on to talk about some growth factors that we can use to stimulate different parts of the bone marrow in terms of the cell lines. So if you remember, we have a stem cell that can turn into white blood cells, red blood cells, or platelets. Well, we have growth factors that we can give patients that can stimulate those different cell lines so that we can increase either the white cells, the red cells, or the platelets. Okay, and we'll talk about why we use those. Won't spend too much time on this slide. This is just showing you how that amazing stem cell can convert into red blood cells, megakaryocytes, which then break off and become platelets, and then all the different white blood cells. Okay, so just as a reminder, this is all happening in the bone marrow. Okay, so let's talk a bit about the physiology of hematopoiesis. What does that mean? It means the process of where the three different cell lines that we just saw in the above slide occur, right? The production of red blood cells, white blood cells, and platelets. And it all begins with the stem cell. And the specific path depends on the body's needs, right? So the body may require more platelets. Well, platelets can be stimulated by a hormone in the body called thrombopoietin. It's made in the liver. Red blood cells can be stimulated by erythropoietin. It's made in the kidney. Right? So the body has some natural growth factors for the stem cell already. And sometimes we want to give an injection to force higher levels of either red blood cells, white blood cells, or platelets. And those are the drugs that we're just going to briefly talk about. Now, why would we need to stimulate production of one of the cell lines in the bone marrow? Well, if somebody has, say, kidney failure, well, they don't produce much erythropoietin, so they become anemic. And so we can use erythropoietin synthetically, it's not a blood product, as an injection to stimulate the bone marrow to produce more red blood cells. There are drugs that we use called chemotherapy agents that suppress the bone marrow. And they suppress them to the extent that the white blood cells are inhibited, the red blood cells are inhibited, and so are the platelets. And sometimes we want to use agents that will increase the white blood cell count because it's so dangerous to have a very, very low white blood cell count because you're at risk for infection. And it can be very dangerous to have a very low platelet count because of the risk of bleeding. Okay, so for different reasons, we use these drugs to stimulate one of the cell lines to increase the level of that particular cell line, whether it's the platelets, red blood cells, or white blood cells. Okay, so here are the three different cell lines. So the erythrocyte or erythropoietic growth factor, that's erythropoietin, typically made in the kidney, but it's made synthetically when the kidney has failed. And that's the most common reason for using it in kidney failure. There's white blood cell stimulating growth factors to increase the white blood cell count, and in particular, the neutrophil count. Why do we want to do that? Because patients that have received chemotherapy can have profoundly low neutrophil counts to the point where they're at risk for overwhelming infection and sepsis. So the most common one that we use is one called filgrastim, okay? Filgrastim, or Neupogen. and we'll talk about that one. And lastly, we can have a thrombopoietic growth factor, meaning stimulation of platelets, and that's called oprelvacin. Okay, and that will increase platelet count if necessary in the setting of having received chemotherapy or in bone marrow failure. Okay, so this is just a slide on erythropoietin. Okay, naturally it's made in the kidneys. So the main reason for using it as an injection synthetically is kidney failure. Okay, so typically we don't use it in chemotherapy when you've become anemic because the bone marrow's been shut down, because you don't have reduced levels of erythropoietin, just because your bone marrow has been suppressed by chemotherapy agents. If your kidneys are working normally, you still have normal levels of erythropoietin. You have abnormally low levels of erythropoietin when your kidneys are failing, and that's where we use it, chronic renal failure. Okay? So here we see erythropoietin on a prototype slide. What's the main indication for injecting it? For patients with chronic kidney disease to increase their hemoglobin. So they're anemic from the chronic kidney disease. We want to improve their level of anemia. We give them erythropoietin shots. We can also use it for someone who's going for elective surgery and wants to use their own blood. We can stimulate red blood cell production by giving them erythropoietin shots. But by far the first indication is the most common. Okay, we've already gone over the action of how it works by stimulating the red blood cells to be produced. What are the main side effects? I would think of the main side effects as its ability to thicken the blood, because you're sending out millions and millions of more red blood cells. So it's going to increase the viscosity of the blood. If you increase the thickness of the blood, that can lead to blocked arteries. So stroke, heart attack, the potential for high blood pressure, the potential to form a blood clot such as a DVT. Those are all due to its blood thickening effect. Okay? Most people tolerate this drug fine, and the hemoglobin is monitored, because once it gets to a proper level, then you don't necessarily need the erythropoietin shots as frequently. Okay, so we monitor the CBC. Okay, let's go on and talk about a white blood cell stimulating growth factor. And before we do that, let's just talk about neutropenia. So neutropenia is a low neutrophil count, and it's typically caused by chemotherapy agents that have affected the bone marrow and reduced the overall white blood cell count, and in particular the neutrophils. And they are so important for fighting bacterial infections that when they're reduced, the patient is at high risk for fevers and potentially overwhelming bacterial infections. Okay, so typically we consider a neutrophil count of less than 1,500 as neutropenia. As it drops below 1,000, it becomes moderate neutropenia, and then below 500 is severe neutropenia, where you're at high risk, and we'll consider using a growth factor to stimulate neutrophil and white blood cell production in the bone marrow. Okay, so always think of when someone's neutropenic, their risk is is acquiring a serious bacterial infection. So we often advise them to avoid crowds, avoid sick people, avoid raw foods, raw vegetables, raw fruits, raw meat, anything that could have potential bacteria in it. Okay? So they have to be very careful. And let's move on and talk about a white blood cell stimulating growth factor. Okay, so leukocyte growth factor. And there's one in particular we're going to spend more time talking about because it's more common. And what do these drugs do? They increase the white blood cell count, and also by doing that, they increase the very important neutrophils. So when can we use these drugs? Well, if a patient has been suppressed by a drug, their bone marrow has been severely impacted by a chemotherapy drug, then we can use one of these colony stimulating factors to increase the white blood cell count. A patient that's received a bone marrow transplant, we can use one of these drugs to stimulate white blood cells to start being released into the bloodstream again. Or anybody with low neutrophils that we want to increase the levels because they're at such a risk for infection. So those are the main ones. Okay? The most important one definitely is someone who's had chemotherapy drugs that's suppressed their bone marrow. Okay, so here's a very commonly one that's used, filgrastim, or known as Neupogen. Again, for neutropenia, typically related to chemotherapy drugs. The autologous transplant, we won't spend any time for that because really we're concentrating on increasing the white blood cell count in the setting of chemotherapy drugs. Okay? Now, this drug is injected. It's going to stimulate the bone to produce white blood cell, and that's where that bone pain comes from, because you're stimulating the bone marrow to produce lots and lots of white blood cells. And by doing that, you're increasing the white blood cells so much in the bloodstream that you can get an enlarged spleen, and potentially even a ruptured spleen, although that would be very uncommon because the doses used are monitored. Okay, so how do we monitor the effects of filgrastim? Well, we want to know what the white blood cell count is, and in particular, the neutrophil count is. So we get a CBC and differential. What does a differential mean? It just gives us the breakdown of all the white blood cells in the blood test. So we'll be able to see the total white blood cell count, but also see the breakdown of how many are neutrophils, how many are lymphocytes, and so on. So we'll be able to determine if somebody is still neutropenic or their neutrophil count has gone above 1500 and they're no longer neutropenic. Okay, but we definitely advise patients that they are going to experience some bone pain with this injection. Okay, so I'm going to purposely not talk about this one. It's basically the same. It's a white blood cell stimulator. It's used to increase the white blood cells, but it's definitely not as commonly used as filgrastim. So here's a slide on it. Maybe just know a bit about it, but I would concentrate on filgrastim first, since that one's more commonly used. Okay, so what about thrombocytopenia, low platelet count? That can occur with chemotherapy agents as well, right? So you can have low platelets from an assortment of different conditions, but definitely these little tiny clotting cells are very, very sensitive to chemotherapy, and they will definitely be reduced during chemotherapy for cancer treatment. And what are the common signs of thrombocytopenia? It's usually surface bleeding, so bleeding gums, a bleeding nose, petechiae, those little spots on the skin, or bruising on the skin, or patients that go and have a dental extraction and they just tend to bleed and bleed and bleed because you can't form that platelet plug. Okay, so think of it as more surface bleeding with thrombocytopenia. Okay, and here is the platelet stimulating growth factor, oprelvacin. When can we use it? In significant or severe thrombocytopenia to increase the platelet count. Okay, so I think if you know that about this drug, I think you're doing fine, because it's not a very common drug. I think it was more for completion's sake, because we were talking about erythropoietin and we were talking about filgrastim. Okay, how do we monitor this drug? Well, with a CBC, since we get a platelet count as part of our CBC. Okay, so it's administered daily. It's a subcutaneous shot, just like erythropoietin or filgrastim, and we will monitor the platelet count to see how it improves on this medication. All right, let's move on to the last part of this module, and that is blood products. And I think we're doing relatively well for time, since each voiceover is typically about 2.5 hours. I know some of them have been longer. I apologize. But I'm trying to keep to 2.5 hours. Okay, so blood products. Well, when you give blood, which is whole blood, it's broken down into its components, sorry. So nobody gets whole blood as a transfusion anymore. You give whole blood as a donation, and then the lab, the blood clinic will break it down into its components, which are plasma, and we call that fresh frozen plasma, since it's cool. It's kept very, very cool. The red blood cells, we call them packed red blood cells, packed RBCs, and then the platelets, and you can get packages of platelets. Okay, the last one is cryoprecipitate, and that was very, very concentrated fresh frozen plasma from many, many different donors, and that was used for patients with hemophilia years ago because it had a very high concentration of clotting factors. We don't use this very much anymore because we now have synthetic clotting factors to replace the absent clotting factors in hemophilia. So in hemophilia A, it's clotting factor 8. In hemophilia B, it's clotting factor 9. So we have synthetic factors to replace them. So cryoprecipitate isn't used as much anymore. The other ones are used very frequently. Okay, so this is just a bit of information. I know you'll see this in pathophysiology, just the blood typing and cross-matching. So when we blood type, why would we want to know someone's blood type? Well, typically, it's because we want to transfuse blood into them, and we want to get the right blood type for them. Okay? And we also do blood types on pregnant women right at the start of pregnancy. Why do we do that? Because we want to see their Rh status. Are they Rh positive or Rh negative? Because that's going to determine whether they get RhoGAM or not. Okay, and here are the different blood types that you can be: A, AB, A, B, or O. And we won't spend too much time on this because I know you've done it in an earlier module, but this slide gives you information on what it means to be AB blood. Well, you have antigens A and B on the red blood cell. You don't have any antibodies in your bloodstream to any of the blood types. So you are a universal recipient. You can get anyone else's blood type as a donation. Let's go to blood type O. There's no antigens on blood type O, meaning you can give your blood to anybody because there's no antigens for their antibodies to attack. So blood type O is the universal donor. Okay? Okay, so let's get back to blood. We had a bit of a sidetrack there about blood types, but let's get back to blood. I think you've seen a similar slide to this. The components of blood, the plasma, which is responsible for carrying all of our nutrients, the hormones, all the proteins such as albumin, and it's that yellowish substance when we spin down a test tube in a centrifuge. It makes up about 55% of the volume of the blood. Okay, the red blood cells make the next largest percentage. They're about 40 to 45%, and we call that the hematocrit. Okay, and what are they responsible for? Carrying the vast majority of oxygen in the blood to the tissues. The platelets make a tiny component, less than 1%, and they are responsible for forming that fibrin clot, that platelet plug that we've spent so much time talking about. And lastly, the white blood cells make a small percentage as well, less than 1%, and they are responsible for the immune system, for fighting infections such as bacteria or viruses. Okay, and remember, there's 5 of them, right? There's the neutrophils, the lymphocytes, the basophils, the eosinophils, and the monophils. The monocytes. The biggest percentage are the neutrophils, followed by the lymphocytes. Okay? Okay, so let's talk about the different blood products. I mentioned before that we really don't give whole blood. Blood from donation is really immediately broken down into its components. So when you give blood, you're actually giving quite a number of components: your red blood cells, your platelets, and your plasma. Okay, so this slide is a bit artificial because we don't do this as much anymore. But whole blood could have been given for acute blood loss. So someone who's acutely hemorrhaging could have received whole blood in the past. Or any shock state. So if you have hemorrhagic shock, which is the same as acute blood loss, by the way, then we could transfuse you with whole blood. But we no longer do. Okay, I'll explain what we do instead. Okay, and what does this do? It increases circulating blood volume. What are reactions to really any kind of blood product? Well, you could have an anaphylactic reaction to the product itself. You could have other allergic reactions to different components of the blood. So you might get, say, a rash, like a minor allergic rash. You could have acute hemolytic reaction, meaning the patient has received the wrong blood type. So they were blood type A and they received blood type B. That's going to result in a massive hemolytic reaction, and the patient's going to be very, very ill. This is extremely uncommon. It happens in about 1 in 30,000 transfusions. Okay? We could give too much volume of a blood product, causing overload in the circulation, especially in someone with congestive heart failure. They can't pump all this fluid that we've given, and they go into congestive heart failure, and the fluid backs up into their lungs. Okay? We can cause fevers with blood products because some of the components of the blood can lead to an inflammatory response in the patient, and we'll talk about that a bit more. What are the contraindications? Well, typically it's for cultural or religious reasons that someone doesn't want a blood product. Okay? So not necessarily whole blood, but any blood product. Now, if a reaction is noted with any blood product, whether we're talking about whole blood, red blood cells, platelets, if there's a reaction that's noted, stop the transfusion and check vital signs. That's the most important. Get your vital signs before the transfusion and during the transfusion. Okay? And a consent form has to be signed by the patient that they agree to receive the blood product and that they are aware of the potential risks of receiving a blood product, such as infections, hepatitis B, hepatitis C, HIV. These are very, very uncommon because blood is now screened, but it's still possible, even though it's a very remote possibility. Okay? Blood is checked by 2 nurses to make sure it's the correct blood. The tubing that is providing the blood to the patient is typically changed after 2 units to prevent any infection, because remember, blood is an organic liquid, and everything has to keep clean, otherwise bacteria would love to grow in the blood. Okay? And that's why typically we infuse blood up to 4 hours. So once we've hung the blood, we can't run it any slower than 4 hours. Okay? When blood is taken out of the fridge, it cannot sit on the counter for longer than 30 minutes. Okay? Because it's warming up. You're running the risk of the blood getting too warm and potentially getting infected. Okay? So 30 minutes on the counter, 4 hours maximum for infusion. Okay, so blood is broken up into its components. Here's one of the components, packed red blood cells. Why would we give someone packed red blood cells? Well, for anemia, and typically if someone has a hemoglobin of less than 7, we will then consider giving them a red blood cell transfusion. And each pack of red blood cells typically raises your hemoglobin by 1 point. So if you were 7, you'll likely go to 8. So sometimes we have to give 2 or 3 units of packed red cells to get them to a decent hemoglobin level. We also use packed red cells in hemorrhagic shock. So if you're bleeding to death, we want to replace your blood loss with blood. And often if someone is bleeding to death, not only do we replace the red blood cells, but now we start to have to replace the platelets, and we have to add fresh frozen plasma, because that is actually what the patient is losing. All 3 of those components. So someone who's having a massive hemorrhage will need fresh frozen plasma, platelets, and packed red blood cells. Someone who's receiving red blood cells just because they're anemic and they're below 7 They'll just receive the packed red blood cells. Okay? What are the adverse effects? Well, the acute hemolytic reaction is you've received the wrong blood type. And that is the antibody in the patient is now attacking the donor blood. And there's a massive hemolysis and red blood cell breakdown. Febrile reactions occur because within the red blood cells, there's still a little bit of white blood cells. They haven't been all completely eliminated, and the patient is reacting to the white blood cells and developing a fever that we can easily treat with acetaminophen. Mild allergic reactions are common. They're typically rashes, itchy rashes. They can be treated with diphenhydramine. Hyperkalemia is only if the blood has been sitting for a long time in the fridge or on the counter and the red blood cells have had time to break down and release lots of potassium. So labs are very careful with how long they keep red blood cells because they get old. And if they get old, they can't use them. Okay, so the hyperkalemia is just from the red blood cells that are breaking down before they've been transfused. And lastly, sepsis. Why sepsis? It's usually from improper handling, right? The blood sat on the counter for too long. The blood wasn't refrigerated properly. The blood was transfused over 4 hours. Something about the improper handling of the blood. Okay, the contraindications, again, it would be for cultural or religious reasons that someone does not want to receive a blood product. We typically will do a CBC after giving packages of packed red blood cells to see where the hemoglobin ended up. Okay, as I mentioned, typically your hemoglobin goes up 1 point per unit of packed red blood cell. Okay, platelet transfusions. So platelet concentrates. And usually we're not going to give a patient platelet transfusions unless their platelet count goes below 20,000. Because platelets don't live very long. They only live for 5 to 7 days. So giving someone who doesn't have a severely low platelet count is a bit of a waste of time unless they're actively bleeding. So if someone has a platelet count of 70,000, we're not going to transfuse them with platelets if they're not bleeding, because they're just going to disappear within 5 to 7 days. Because 20,000 is very, very low, they're at high risk of bleeding. So we will transfuse patients with platelet counts below 20,000. Or with any other patient who has significant thrombocytopenia and is also actively bleeding, we can give them platelet transfusions. And you can still get as an adverse effect fever that we can treat with acetaminophen, mild allergic reactions that we can treat with diphenhydramine. And again, it's a blood product. Bacteria would like to grow in it. So if it's improperly handled, you could get a bacterial infection or sepsis. Because it's a blood product, it would be contraindicated in patients who have cultural or religious beliefs that they do not want a blood product. Platelets are transfused through a special platelet filter with short tubing because the platelets, it's to avoid the platelets from sticking to the tubing. And they're infused relatively quickly. Each packet or each unit is given in about 15 to 30 minutes. So much faster than a red blood cell transfusion. So some patients need 5 or 10 units of platelet concentrate to get their platelets to a proper level. Okay? Okay, what about fresh frozen plasma? Well, what is that? What is fresh frozen plasma going to be very rich in? It's going to be rich in clotting factors, okay? And that's where we use it. So if someone's having a massive hemorrhage, we can't just replace the packed red blood cells, or sorry, the red blood cells. We need to replace the clotting factors that they're losing in their hemorrhage. We need to replace the platelets as well. So they get all three of them: red blood cells, platelets, and plasma. Okay. Uh, as well, we can reverse warfarin with fresh frozen plasma. So if someone is not bleeding and they have an elevated INR while they're on warfarin, no problem. We can give them vitamin K to reverse some of the warfarin effects and have the INR come into a reasonable range, such as 2 to 3. Vitamin K takes around 24 hours to work. So we really can't use it for someone who's bleeding to death while on warfarin. We need to use fresh frozen plasma because it's full of clotting factors. So it's a replacement of all the clotting factors that are missing because of the warfarin, plus all the others. Okay, so it is the reversal blood product for warfarin. All of the adverse effects will be very similar to other blood products. Whether it's an acute hemolytic reaction, that's unlikely, but you can get fevers, you can get mild allergic reactions, you can get fluid overloaded with too much fresh frozen plasma. Okay, so just keep in mind why you give fresh frozen plasma. It's typically to replace the clotting factors or to reverse someone who's acutely bleeding on warfarin. Okay, what about albumin? Well, albumin is a large molecule and it's a blood product. And we use albumin when a patient's albumin level in the blood, so the serum albumin level, is too low. Why would someone's albumin be too low? Typically because they have liver failure or cirrhosis and they are no longer making albumin. And what happens in that case is they have lost their oncotic pressure and they get peripheral edema in their legs. They get leaky everywhere. So they get ascites, which is that very large abdomen you saw in a previous module. They get pleural effusions, which are fluid collections outside of the lung in the chest cavity, because the blood vessels are so leaky and they're not reabsorbing the fluid because of loss of oncotic pressure. So someone who has cirrhosis and massive amounts of ascites or peripheral edema can be given albumin to improve their oncotic pressure. So when we take fluid out of someone's abdominal cavity, called a paracentesis, a thoracentesis is when we take fluid with a needle through the chest wall out of the thoracic cavity. We might give an infusion of albumin so that the fluid doesn't come right back. It maintains oncotic pressure so that the blood vessels can reabsorb the fluid from the interstitial space. Okay? So what's the adverse effect of albumin? Well, you're forcing more fluid to stay in the intravascular space, so it does have the potential to volume overload, especially someone with congestive heart failure. Okay? Okay, so I saved this slide for last. So, white blood cell transfusions. This is extremely uncommon. We almost never do this. Okay, so whether it's for severe neutropenia or a life-threatening bacterial infection, this would be extremely uncommon. I've actually never seen this done. Typically, if someone had severe neutropenia, we would give the growth factor called filgrastim, okay, to increase their neutrophil count. We'd put someone on antibiotics to protect them from bacterial infections. But I put this in here because I think you're going to see it in your book. Very, very uncommon. Okay? It'll have all the same adverse effects to any blood transfusion. And that's all I'm going to say on it because it really would be an unusual blood transfusion or blood product. Okay, and we're done. Under 2 hours and 30 minutes. I hope this helps you. Go through the slides with the voiceover. Make sure you understand the slides and what I'm trying to explain about the slides. Get the big picture. The tiny little details of the coagulation cascade, whether it's factor 9 or factor 12, is not important. It's the big picture that's important. Okay? So, drugs that inhibit platelets. Okay? Drugs that inhibit the coagulation system. Okay? What do? Well, antiplatelet drugs, they stop the platelet plug. Anticoagulant drugs, they stop fibrin formation. So get the big picture of topics, because that's what'll stay with you, and that's what's going to help you formulate and decide on answers during tests. It won't be the tiny, tiny details typically. It'll be the bigger concepts, to see that you understand how to come to an answer by putting multiple concepts together. Okay, so I hope this helps you.